Welcome to Tellico Health Chat, a series of programs about relevant health and wellness issues, produced and presented by the volunteers at Tellico Village Broadcasting.
Hello and welcome to another episode of the Tellico Health Chat. I'm Ashley Hankliff for Covenant Health. You hear it almost all too often about folks who are dealing with numerous types of neurological impairment, whether they are suffering these effects from having a stroke, brain injury, multiple sclerosis, ALS, Parkinson's disease, or others. Today we have with us three important clinicians from Fort Loudon Therapy Center who work directly as a team with patients that are rehabbing from neurological effects. Ann Ross is a clinical specialist and speech-language pathologist. Janelle Bell is an occupational therapist, and Gail Hammer is a physical therapist. Thank you, ladies, for being with us today and discussing these topics that we know will be of interest to our viewers here in Tellico Village.
Thank you
for having us.
Mm-hmm.
So first off, I want to talk about issues that folks may be dealing with from these effects. And Ann, I guess I'll start with you if you want to talk about that, and then we'll go into your background and what each of you do at the center.
Okay. Well, basically, when we're looking at neurological impairment, we're looking at a brain injury, whether that's due to stroke or Parkinson's or ALS. It's a brain injury or an illness to the brain that affects that patient's independence and function. So as therapists, we want to address returning that patient to as much functional independence as possible, or maintaining function for as long as possible in the case of diseases that are progressive, such as ALS or Parkinson's or MS. Most people have come in contact with someone who's had a stroke or Parkinson's, although they're not necessarily common illnesses and injuries. They're not unheard of in the community. For example, stroke is the leading cause of disability in the U.S. It's also the most preventable cause of disability, affecting about 795,000 people a year in the U.S. Parkinson's, the data shows about 60,000 new diagnoses per year for Parkinson's and about 6,000 for ALS. So again, with all of these types of brain injuries, or it could be a traumatic brain injury such as a motor vehicle accident or a brain tumor, anything that affects brain function is a neurological impairment, and that as therapists, speech therapists, occupational therapists, physical therapists, we want to work on regaining that patient's independence and function to the maximum level that they are able to have that regained, or again, maintain that independence for as long as possible.
And as we age, our bodies change, and sometimes we begin to experience changes in our abilities to do things. Oftentimes, people will start to accept these changes as just normal aging, and so they don't seek any medical attention or evaluation for these things, but they will start to rely on family members or friends to do more things for them, or maybe the job that they were doing or the role they played in their home. Until there's a significant decrease where suddenly the family isn't able to take care of them, and that may be the first sign that, or first time they get to seek medical attention. Or they might have a sudden decrease in function, such as having a stroke, or to have that injury, that fall that creates a traumatic brain injury. And then they'll seek emergency attention. They will get some therapy when they go to the hospital, especially physical therapy, because they will be first getting them up to get them moving again and assessing their ability to move. They may receive some speech therapy in that hospital setting because they may have had some trouble swallowing or in talking. But once they get to where they can kind of do a little bit of their mobility in the home or in the hospital, they may just be discharged back to their home. Or they may be transferred to an inpatient facility such as Patricia Neal Rehabilitation Center, or to a skilled nursing facility that might be in their area, in which there they will receive additional therapy such as PT, OT, or speech therapy. But the goal of that center is to get them good enough to go home. So their focus is really on just getting their skills up to the level that they can return to their home and be managed by or helped by their family members or friends. So, but they may still have some functions that are not back to their normal level before. And this is what we kind of come into when they have these undiscovered or may not know that they have these trouble. They might find this out when they go to church or go to a movie theater and they can't walk sideways to get into the pew or get into their seat in the theater. That they can walk forward, but going to that sidestepping is harder for them. They may get home and they can't balance their checkbook. They may not be able to open their mail because they're having some incoordination difficulties with their hands. They may have trouble formulating the grocery list just to go to the grocery store. And so these are areas where outpatient therapy can come into play for people. Therapy that helps with these changes, they can improve a person's ability to be independent. And so they may need multiple therapies or just one specialist depending on their area of need. So therapy for these changes in abilities can often improve one's independence or their level of functioning. So depending on the nature of their problem, they may need therapy in one or more areas or one or more specialists to help them.
Okay, then now that we have discussed some of the issues that affect folks with talking about neurological impairment, can we go into specifics about the role that each of you play in treating the patient, and also Gail? So Anne, let's start with you. You're a clinical speech and language pathologist, so can you talk about your background and your role in treating the patient?
I am a speech pathologist or a speech therapist. The terms are somewhat interchangeable, means the same thing. I've been a speech therapist for about 32 years. I've been with Covenant Health for 17 years, and of course Fort Loudon is part of Covenant Health. I've worked in acute care hospitals, outpatient centers. I've done some home health and some skilled nursing facility therapy. Worked with children and adults, but my passion, my love is working with the adult population, particularly those with neurological impairment. As a speech therapist, I work with patients who have difficulty with communication and with swallowing. I think the term speech therapy can be somewhat misleading because it's not just speech. We do so much more than just work on the articulation, although that is part of what I do. I also work on voice, for example. The voice can be weak, hoarse, raspy. In fact, with Parkinson's, one of the primary characteristics is a decline in vocal loudness. Family members will always or often tell that patient, "I can't hear you, you're not speaking loud enough." But to the patient, they feel like they are. But with that disease progression, their voice becomes softer and softer and harder to hear. So sometimes there's some withdrawal because they can't communicate. And that's where our clinic offers a program called LSVT Big and Loud, which stands for Lee Silverman Voice Therapy. And the big is the OT physical therapy portion. I deal with the loud portion of that program, where we work with patients primarily with Parkinson's, but there are applications to other diseases as well, to get that voice louder, stronger, have more endurance, so that that patient can communicate in any situation. I work with communication. So that includes also language, comprehension of what people say. Often after a stroke, a person may have trouble understanding or processing what they hear. It could be as simple as a basic yes/no question, or it could be listening to the news on TV. That also carries over to written language, ability to read and understand and remember what they read. Again, with language, it could be getting the words out. Often a patient knows exactly what they want to say but can't think of the word that they want to use. So that causes a lot of frustration. It can be trouble putting sentences together, forming higher level thoughts. Again, writing is a form of communication. So if there's trouble remembering what word they want to use or how to formulate a sentence or how to spell, we work on that. A lot of what I do is cognition, which is memory, ability to attend to task, multitask. You know, can you listen to the news on TV and wash the dishes at the same time? Or if you're balancing your checkbook and your spouse tells you they're going to run errands, can you remember and deal with both at the same time? Those are the type of things that I deal with also. Many of the patients that I work with also have difficulty swallowing, also known as dysphasia. That's a large percentage of what I do. Most neurological injuries or disease processes cause some trouble swallowing at some point. For those patients, they may have trouble chewing, getting the food or liquid to go into the throat from the mouth due to muscle weakness or discoordination. Once they have swallowed, often food will feel stuck in the throat, or they cough, get strangled very easily because food or liquids going in their airway, which is known as aspiration, and that can cause, potentially cause pneumonia. So my role as a speech therapist is to diagnose the difficulty swallowing that the patient has. Part of that is, just seeing the patient eat and drink, and I do my assessment, but also we do x-rays of the swallow called a modified barium swallow study, and I do those at our hospital at Fort Loudon Medical Center. That's a critical part of the diagnosis because we can see on x-ray what's actually happening to that food and liquid as it goes down. So in therapy, I work on exercises and strategies to keep the swallow safe, figure out with the patient what the safest food is, and hopefully progress them to the point that they no longer have to have tube feeding, if that's the case, or to maintain a regular diet consistency. A lot of what I do with all the areas that I work with, communication, reading, writing, speech, and swallowing, is also working with the family or caregiver on a home program. We always want to give our patients things to do at home that helps them recover faster, helps them carry over the skills that we are teaching in our clinic into their home environment and into their community. The main takeaway is that with therapy, a great deal of progress can be made.
Great. Janelle, let's move on to you. You're an occupational therapist.
Yes.
Can you explain to our viewers what exactly that means, why they might need you, and your role in taking care of the patient?
Okay, yes. I'm occupational therapist, and I've been practicing for 26 years. I started my career at Patricia Neal Rehabilitation Center, where I worked on an inpatient stroke team for approximately a year, and then moved into the outpatient department, where patients had been discharged from the hospital and then came back in for just therapy treatments, and worked with adults and children in that setting for a number of years. Then I transitioned into the school systems, where I worked with people that had children in any age from 1 to 22 that had developmental disabilities. And from there, I have now returned to the adult neuro setting approximately 7 years ago, because I love working with people that have issues that by working on them, they can get back to doing what they wanted to do with their lives and their life roles. And so I have been here now for 7 years, and I just love seeing how amazing the brain is when we can make changes even after even years of difficulties. So as an occupational therapy is a holistic therapy that looks at what a person does in their life, in their daily roles they play in their family or in their occupations. And then what I do is look at what movements they're having trouble with. They may have sensory changes from their neurological problems. They may have visual problems. They may have perceptual problems or some cognitive problems. And I look at what how those components are making them have trouble doing their daily living task or their occupational task. And then I use prescribed activities where I break down the task or break down the skill into little pieces, and then we work on those pieces. It might be that if they're having trouble from movement perspective, that we're working on very specific parts of the movement so that they can get back to doing that. I might use puzzles if they're having trouble with some perceptual issues to relearn the relationship between parts, how to see things in quicker, to how objects are related to each other. These are very important skills that are needed for driving. If you have trouble understanding what's in front of the other object, then you're going to have trouble negotiating the road and whether you need to turn at this point or at a different point. I may use games to work on people thinking through scenarios to get them to think quicker, to be able to perform a task faster, or to alternate between I'm working on cooking, but somebody's going to talk to me. Do I make sure that I don't cut my hand with the knife because I was chopping that potato at the same time? So those are a lot of the different areas that I work on. I work first to try to get back what they knew how to do before. if it's an adult. But if there's going to be a functional limitation that we feel is probably going to be there, then I'm also going to work on what else we can do. Can we do something a little adaptively? Can we have a different strategy for doing it? Or there's adaptive equipment out there that might allow a person to still do the same thing independently, but using this piece of equipment. And so I teach people how to do that.
Okay, next with us we have Gail Hammer, who is a physical therapist at the Fort Loudon Therapy Center. Thank you for being with us, Gail. Can you tell us a little bit about your role at the center as a physical therapist?
Sure. My name is Gail Hammer. I've been a physical therapist for over 30 years in different capacities, including acute care, inpatient rehab, and outpatient. Outpatient is one of my favorites. I've also done a stint in home health, and that gives me an idea of what people are really functioning as in their home. If they tell me they have a flight of stairs, sometimes that can mean different things to different people. So a lot of times what we do first as a physical therapist evaluation is to work on someone's fall risk. Particularly in folks that have a neurological deficit of some sort or a problem that they're dealing with. They might have weakness on one side of their body as opposed to the other side. So they might have a left arm and leg that are weak, when their right side is functioning perfectly fine. If they're having visual deficits or sensory loss where their fingers are numb and their foot is numb, they may have trouble with balance. A lot of times people think of physical therapy primarily in orthopedic types of cases, and certainly we treat lots of knee, shoulder, back, hip kinds of issues. However, when we're dealing with neurological deficits, our main focus is how someone is able to safely negotiate around their environment. Are they safe walking without any help, or do they maybe need a hiking pole or a straight cane or a rolling walker? And depending on the results of the testing that we do, that might help us determine to safely recommend one of those devices for someone to use as they negotiate about their community so that they can get out of their home, walk in their yard, maybe go back to gardening or the exercise class that they enjoyed doing previously. We work a lot on balance, on gait, on general strength and endurance. It's important with research that's coming out now to really focus on the specific type of exercise, the intensity of the exercise, and primarily, like I said, with neurological deficit, we're working on balance risk, fall risk, and making someone or helping someone to be safe in the manner that they move around their home and community. We don't want people to be limited just to their home. We want them to be able to feel safe and confident. And if you notice a family member who is starting to hold on to furniture as they walk through the home, or is starting to veer or stagger, starting to take very small steps, not swinging their arms, not looking side to side, making sure they have a buggy when they're in the store because they don't feel safe walking through without. Those kinds of things can be kind of a light bulb moment where you go, well, you know, maybe they could benefit for some physical therapy, some occupational or speech therapy, because they're not functioning as they used to. Maybe they start staying home and sitting more because they don't feel confident about moving about. They're afraid of falling. But they might be afraid of telling a family member that because they don't want to lose their independence. Well, we're all about helping people improve their independence. And sometimes that involves using a walking device or doing certain exercises to really recapture their strength, their coordination, their balance. And we are glad to help people do that. Part of the LSVT BIG program are specific exercises for Parkinson's that involve large amplitude movements, direction change, balance, feeling more confident in their ability to exercise and to produce larger amplitude types of motions. And again, reducing their fall risk and improving their ability to move about safely. those types of exercises with the LSVT Big and Loud, we offer it for it loud, and with our certified therapists, all of us are certified in that certain exercise protocol, and we really enjoy teaching it. And it involves an intense program of 4 days a week for 4 weeks. And then we always, as therapists, give you homework. So sorry about homework, but that's important. And with any therapy program, we're going to give you exercises and balance training to do at home. We always sit down with folks and ask them what their goals are. That's the most important part of sometimes our outpatient therapy approach, is that we work as a team together. And we also want to make sure that we're addressing your goals. If your goal is to go back to yoga class, or be able to play pickleball, or to be able to go back to the golf course and play 18 holes of golf, whatever your goal is, whether it's getting in and out of bed easily, getting up and down from those low chairs at the restaurant, anything that you find important, that's what we want to address with our therapy program.
I want to thank our guests today, Ann Ross, Janelle Bell, and Gail Hammer from the Fort Loudon Therapy Center, for sharing their expertise specifically about neurological effects and their rehab available to folks in the area. And thank you, Tellico Village, for watching our health-related videos. As always, if you have questions or suggested topics, you can reach us here at the station. And if you have questions specifically for the ladies at the Fort Loudon Therapy Center, you can contact the Fort Loudon referral line at 271-6060. Thank you and have a great day.